Knee deformities in adults. Usually these deformities are unilateral, but they can be bilateral as well, although quite rare. Why? Because if there would have been a residual deformity of, let's say, the child had rickets, was left untreated, and the child may have gone into or grown up to be an adult, but the child can still have a bilateral board leg as well. Usually it's very rare, but in the case of adults, mostly it's the unilateral deformity, which could be unilateral genu valgum, genu varum, or it could be most commonly the genu recurvatum as well. The deformity in adults could be in form of a 3D deformity. For example, if you see this is classical example of a unilateral genu varum. Whenever patients with adults come to you with a history of a genu varum, then you have to rule out on the examination what was the basically cause of this. Was there any history of trauma? Was there any history of fall? Was there any history of physical damage during the childhood or during the adolescent age? Because usually if these patients have some sort of a history of a trauma or a physical damage at a young age, once the physes have damaged, the growth stops at the, for example, if the medial side of the physis would have been damaged in the distal femur due to any trauma or any iatrogenic physeal damage, the growth usually stops, and as a result the lateral physis continues to grow, and it results in this kind of a rotating deformity in which actually the distal part of the leg or the tibia goes more towards the center in form of, and leading to unilateral genu varum. The patient initially may not have a very severe form of a genu varum. As a result, it continued to move on. But once the genu varum progresses to a point where during the normal gait pattern, this feet starts colliding with the other feet, then the patient may have a problem with a normal walking as well. Therefore, these usually people come for the treatment once the stage has progressed beyond a point where they can compensate by their postural mechanisms, and therefore usually these deformities, when they present an adult, they may have a very severe form of a genu varum or even genu valgum as well. Therefore, once you know this is the situation which comes in, then probably you need to do some form of corrective osteotomy at the distal femur. So but you have to, if the problem was at the distal femur, then you have to treat the cause there and then, and we have to go for some form of a closing valgus osteotomy in the distal femur to correct this unilateral genu valgum as well. Once we know what was the underlying cause, once we know what was, if we have to rule out, get the x-rays of the knee, preferably both knees, including the whole length of the tibia as well as the ankle and the hip joint, because there may be something else as well. There may be some form of a metal work which may be present as well in form of screws. This could be even iatrogenic problem as well. The patient may have some form of Salter's type 2 injury, and the screws which will actually pass right through the physis. This may be leading to this sort of a problem as well. Therefore, you need to assess it completely. Is there any metal work on there or not? What is exactly the angle between the tibiofemoral angle, and what is the situation of the medial as well as the lateral physis? And then once you have calculated it as the other side is normal, you have to calculate the other side angle as well and bring it normal physiological range. For example, if this person is having a genu varum of about 20 degrees, and you know this normal physiological genu valgum is about 5 to 7 degrees in adults, therefore you know you have to compensate for about 25 degrees. Therefore, when you're doing the osteotomy, you have to do an osteotomy so that actually the 25 degree compensation is being made on the other side. And then you have to calculate how much wedge you need to take, and how much graft you need to put in. All these calculations has to be made on x-rays before going for some form of a surgery. And in adults, mostly you have to go for surgery, because otherwise this will not correct over the period of time. Now, genu recurvatum. This is actually more common in adults as compared to genu varum and genu valgum. Genu recurvatum is actually, if you see the physiologically, the knee range of motion is from -10 up till 130 degrees, and in some case it's up to 140 degrees as well. That is up to 130 degree of flexion and minus 10 degree of recurvatum. Normally if this recurvatum is more than minus 10 degrees, or there is excessive genu recurvatum, this can present with the deformity of the called as genu recurvatum, in which actually when these patients extend the knee joint, there is excessive tibial dorsiflexion, and this may be more than 10 degrees, which is normally present in any other knee. Now, if this is a problem which happens, then you have to assess is it due to ligamentous laxity. For example, patient may be suffering from problems such as Ehlers-Danlos syndrome or Marfan syndrome, in which there is a generalized ligamentous laxity because the ligaments are lax, therefore the movement of the tibia is more than 10 degree in any plane. If the patient presents with these genu recurvatum deformity, there are certain differentials you have to look for as well. For example, you have to look for what is the LLD of the patient. Is there any LLD which is actually leading to this sort of deformity? Is there any neuromuscular disorders such as CP or polio, or is there any congenital disorders which patient may be presenting with these sort of problems since birth? Is there any ligamentous laxity? Is there any underlying syndromes such as Ehlers-Danlos syndrome, Marfan syndromes, or is there any associated quadriceps contractures which may be present due to certain previously as well? Now all this has to be kept in mind, and then you have to plan accordingly. You have to get detailed history, examination, and analyze whether it's unilateral or bilateral. If it's bilateral genu recurvatum, you must rule out ligamentous laxity as well underlying problems such as Marfan and Ehlers-Danlos syndrome as well. Now, if your patient does comes with genu recurvatum with severe destructive arthritis, and this is the situation, and you can very well appreciate from the side is that this appears to be a unilateral rather than bilateral, then you have to look at what is the age of the patient. Can you go for some form of a corrective surgery, or you need to go for some form of a surgery to deal with arthritis? If, for example, patient may have an excessive genu recurvatum, but there is no severe form of arthritis which is present, then we can go for some form of a corrective surgery at the proximal tibia. But if this patient comes to you with a history of genu recurvatum with severe arthritis of the knee joint, then the patient will still have pain despite having a corrective biomechanics correction as well. Therefore, probably not only you need to do some form of corrective surgery, but also need to go for probably the TKR, the total knee replacement in this case as well. But then again, you have to assess as a whole whether what is the age of the patient, how much arthritis is present, what is actually underlying cause of the arthritis, and is it some form of a quadriceps contractures, biomechanics problem, or what is actually wrong with this, where things can be a problem here. Therefore, before embarking for any surgery, you need to get CT scanogram, you need to measure whether there is any LLD or not. What about the situation of ankle? How much ankle is stable or not? If the patient may having arthritis along with the genu recurvatum, but patient is also having underlying poliomyelitis, and patient does not have muscles which are well developed at the ankle joint, then probably doing a TKR in that case would be more of a disaster rather than doing any good to the patient. Therefore, whenever this patient does comes to you, you have to analyze as a whole what is actually the underlying cause which is causing the genu recurvatum, what is actually causing which is leading to this problem, and what can be done regarding genu recurvatum and underlying cause which is present in the patients. This is how much genu recurvatum can be present as well. You can appreciate this is almost more than 30 or 40 degrees of genu recurvatum. Now, if it's bilateral, you have to assess as a whole patient. Patient may have certain other generalized ligamentous laxity as well. You have to go for Britton score. That is, you have to ask them to do it like this. That is, if their thumb is actually touching the inside of the forearm, this is 1 point. You have to do it on the other side as well. That becomes 2 points. If your this little finger is going beyond 90 degree, then it becomes 1 point, and fourth point is going for this as well. You have to ask them to whether fully extend their forearms. If there is hyperextension at the forearm or at the elbow joint, this means there is also 1 point on the both sides. That this becomes 6 points. You have asked to extend their knees. If it's hyperextension in the knee joint, it's 2 points as well. And then you have to ask them to bend forward to look at the laxity of the spine. If it's also there, out of the 9, if its score is 5 or more than 5, this means actually the patient has generalized ligamentous laxity. In that case, probably surgery will not be a good option, because the ligaments would still be lax. Even if whatever the surgery you do, it would actually still the bone will come out. Therefore, you need to give them physical strength only and ask them to develop muscles in the form of exercise. And actually the quadricep training is more of importance rather than going for any surgery. So if patient does not have any underlying associated problems such as Ehlers-Danlos syndrome or ligamentous laxity, and there's no neuromuscular disorders such as CP or polio as well, and patient may have due problems like certain to contractures of quadriceps or anything which is maybe due to trauma or malunited fracture, the patient may present with actually a genu recurvatum. We can go for osteotomy, or depending upon whether the malunited fracture is present at the proximal tibia or distal femur, where the correction can be required. If you see this is one form of correcting the excessive genu valgum by using a posterior closing wedge osteotomy, in which you actually this is how the osteotomy has been done, and gradually the tibia is moved backward. Even despite having an excessive recurvatum, this would actually correct the genu recurvatum by actually correcting the slope of the posterior tibia. Therefore, this is one way of correcting the genu recurvatum by use of osteotomy at the proximal tibia. In this lecture, we have briefly gone through the problems which is usually present in the knee joint, especially in the case of the children. Mainly, it's the genu varum and genu valgum. Before moving on then discussing the pathological causes, one has to understand that basically there is also a physiological genu varum which is present up to 2 years of age. Then it peaks to genu valgum at 3 to 4 years, and it goes up to 7 years as well. You have to keep that in mind before assessing the child, whether the child is having a pathological genu valgum. Plus, you need to take detailed history, clinical examination, and then according to age as well as the access, you need to plan accordingly. And sometimes all you need to do is just counseling with the parents that this is a physiological phenomena and it's going to correct by its time. Thank you very much. Keep watching sqadia.com.